Greetings. Let me share with you about endoscopy during COVID-19 pandemic, how to stratify endoscopy cases based on the emergency need for the procedure and their COVID status. I would like to acknowledge grant support from John Stoline Endowed Professorship, Mr. Charles Butt and H.E.B. Grant, and medical illustrator Ms. Angela Deal. These are the different topics I would like to cover, and for this video let me focus on risk stratifying endoscopy cases. One of the most important things that the endoscopy faculty should know and decide is what type of cases are they going to do. You could divide endoscopy cases into urgent and life-threatening, semi-urgent. Those are the cases that could become worse if you do not manage them in a timely manner, and then elective cases where you could postpone them without causing any adverse impact on life. So, the urgent indications include acute life-threatening GI bleeding, GI leaks and perforations, biliary sepsis, foreign bodies, GI obstruction requiring a stent, and GI access for nutrition. So, these are the urgent indications that need to be taken care in the middle of the COVID pandemic. Semi-urgent cases are cases that one should weigh and discuss the pros and cons, and these include resection of gastrointestinal neoplasia, when there is a suspicion of cancer, enteroscopy for occult GI bleeding, ERCP for cancer with obstruction. And then coming to elective cases, these could be deferred until further notice, and one should wait until the pandemic passes. The indications include any diagnostic surveillance endoscopy for Barrett's esophagus, colon polyps, IBD, gastrointestinal metaplasia, or patients who have had history of prior GI cancer. And therapeutic procedures for non-cancer diseases, such as somebody requiring management of GERD or weight reduction procedures. And then comes the EUS for benign lesions and ERCPs for asymptomatic stones, therapy of chronic pancreatitis, stent removal or exchange, ampulectomy follow-up, and non-malignant conditions. So, this is a list that was prepared by the Asian Pacific Digestive Endoscopy Society with the lead author Dr. Chu. We want to thank them, and in our group at MD Anderson Cancer Center, we have actually used the same list of indications for urgent, semi-urgent, and elective procedures. So, once you make a list, then the next step is to figure out, and as a group you have to decide that there are cases that need to be done, like the urgent cases, and there are elective cases that will be postponed. You need to work with your endoscopy schedulers to postpone them, and there are semi-urgent cases that need to be decided. In our group, what we have done is we used a panel of senior endoscopy experts to look at the cases and then decide if a semi-urgent case needs to be done or it could be deferred. When it comes to elective cases, our group consists of several endoscopy faculties. We reviewed the cases and then decided which ones could be postponed and some of us even contacted the patient directly by phone to reassure them that they could wait for some time and not risk getting infected with COVID-19. So once you make a decision and you schedule an emergency procedure, especially if the patient is coming from outside, there should be a screening procedure. The nurse should call one day before the endoscopy to review the symptoms, especially fever, respiratory symptoms like cough, shortness of breath, sore throat, etc. And one should also keep in mind loss of taste and loss of smell are also important symptoms to consider, as well as loose stools. And one should also consider whether the patient has had contact with anybody with a proven case of COVID-19 in the last 14 days, and if they have had a travel to COVID-19 area. If there is suspicion, if somebody has symptoms, contact, travel, they should be sent for a COVID-19 testing so that they could figure out whether they have COVID-19 or not. So the most important thing is before the patient comes to the endoscopy unit, there should be a nurse calling them and triaging them and then assessing the status of the patient in terms of the COVID status. So based on the symptoms, the Asian Pacific Society came up with FTOCC, fever, travel, occupation, that is physicians, nurses, healthcare workers, first responders as well, contact with patients with COVID-19 or a cluster of cases. If based on these symptoms and if the test is available and the test result is positive, negative, or the test is not available, they have helped us to identify and stratify patients into 5 different groups. The first group consists of somebody with the symptoms of infection and the test was positive. Second was symptoms of infection, test negative or not available. And the third one is a patient doesn't have the typical symptoms, but they have respiratory symptoms. And finally, somebody who doesn't have any of the symptoms and the test is negative. So there are different ways you can actually divide them into. If somebody is symptom positive, test positive, they are very high risk for infection. If the symptoms are positive but you do not have a test to do, you should still consider them as high risk. On the other hand, if the symptoms are negative, that is fever, travel, occupation, contact or cluster negative, but they have some cough or a little bit of shortness of breath and you don't have a COVID test to do, they are grouped as intermediate in risk. On the other hand, if they don't have any symptoms and the test is not available, they are considered as low risk. And lastly, if the test is negative, irrespective of the symptoms, they are also grouped as low risk. But one has to keep in mind there is a false negativity of the test, and that should be kept in mind. And maybe when symptoms are positive, test is negative, if the case is not emergent, not a bad idea to retest them. And this is not part of their protocol, but something to keep in mind. So why is this important? So when you identify a high risk patient during the triage, then you should let the endoscopy team know about that patient so that special precautions could be taken. And these cases should be scheduled at the end of the day or the end of the procedure list so as to minimize and avoid cross-infecting other patients. So when the patients come in, If they're coming as an outpatient, it's very important to maintain the social distance. Everybody should wear a mask. Everybody should do hand hygiene, and relatives are not encouraged, are not allowed into the endoscopy suite. And this is something very important to keep in mind. For those who are low risk, in the initial triage, they are negative for symptoms, the test is negative, they should be rechecked again when they come to endoscopy. You should ask the screening questions again, you should check the temperature again, so as to catch anybody that develops infection symptoms later on, in between the phone call the day before and their appointment. And this way you could find somebody who is initially low risk, but they could have moved to intermediate or high risk. And this is very important so as to plan the next steps. When they come into the endoscopy unit, we should minimize the number of caregiver exposure. We should be very diligent in cleaning the surfaces with virucidal wipes, and everybody should wear PPE according to the protocol. As far as the endoscopists and the nurses are concerned, you should maintain the social distance as far as possible, and that is very important to consider. And also not a bad idea to change from written consent to a verbal consent so as to minimize exposure. I want to thank the Asian Pacific Society for sharing this nice guideline. And what we have done at our institution is we followed the guideline. The only thing is all our rooms could be converted into negative pressure. So we have negative pressure endoscopy rooms that allows us a little more advantage. Even in those low risk cases, we perform in negative pressure rooms. And in our unit, we use N95 mask that is reusable. Hence, we apply a surgical face mask over it to limit contamination, and either goggles or face shield, gown, and gloves. So this is what a PPE should look like for droplet infection prevention: hairnet, face shield or goggles, surgical mask, impermeable gown, gloves, and shoe covers. And for airborne infection, the same: hairnet, face shield, goggles, N95 mask with or without surgical mask over it, impermeable gown, gloves, and shoe covers. It's also interesting to note that in the near future you'll hear how we can actually make face shields in our own lab, and there is a video that is coming out in Video GIE quickly in the next few days from London. I will share that with you as soon as it becomes available. Thank you.